Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me, as always, is CMIO CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. James Blum. James, or Jim Blum, is the Chief Medical Information Officer for the University of Iowa and an Associate Professor of Anesthesiology with certifications in critical care and clinical informatics. He's an NIH, BARDA, and VA-funded investigator focusing on using large data sets to predict critical illness after surgery. In his current capacities at the University of Iowa, he is looking for ways to utilize information technology to not only improve direct clinical care, but utilize the data created from the electronic medical record and other systems to further the organization's tripartite academic mission. Jim, Dr. Blum, welcome to the show.
Thanks. It's a pleasure to be here today.
Absolutely. It's a pleasure for us to have you on. You've led a truly fascinating career centered around technology for the most part, medicine and patient care, of course. Unlike most physicians who start in life sciences or health sciences, you actually had a degree in computer science first. And so the question to start off the podcast, why computer science initially, and what was the turning point for you to go into medicine?
Yeah, so that's a bit of a long story. So I was growing up and really had a love of computing from very early on in my career or in my life. My parents bought an Apple IIe when I was, I think probably about 5 or 6 years old, and really started to work on programming and computing in general. And then I found myself in high school, then being at an interesting high school that was focused on new forms of education and had some grant funding, in that was one of the first high schools ever connected to the internet. Actually, this was in like 1990. And I was very fortunate to be sort of very on the tech side of it. They really let me, really assist with the implementation and the connectivity and all that. And I went through my college career thinking I was going to go into computing. My goal was actually, to get a job in Silicon Valley, worshiped at the temple of like Bill Joy and, the folks at Sun Microsystems at the time. And in college, my grandfather passed away sort of unexpectedly from metastatic bladder cancer, that it's not clear that the path report was actually his path report that he got results on, and made a decision for a incomplete resection of his tumor versus having a cystectomy. And so it really, I think, was a medical information error that led to his death. And so at that point, I was a junior in college, and I was, starting to think about going into, looking for my first job that would, potentially be in California or something like that. And then going off and getting an MBA and being rich. That was the plan. And then I sort of converted to saying, okay, I want to apply this information technology stuff and computing to the betterment of healthcare and mankind. It was a very different time, right? EMRs were not really prevalent. They were mostly billing systems, all the things that a totally different world than we live in today. And so that was the pivot.
Did you take time to make that decision? Like, did you spend a year working in Silicon Valley or in a company?
So that was my junior year of college that occurred. And so I spent I was actually scheduled that following semester to go overseas. So I spent a semester overseas. I really contemplated what I wanted to do. And then I came back and decided, okay, I'm going to do this. So I actually ended up spending an extra year doing all the prereqs, and then applying to, I took a job at Duke as a research assistant, working in clinical informatics there with a gentleman named Ed Hammond and Joseph Hales, who are, fairly well known folks in clinical informatics, while I applied. And so I had a good idea of what I was getting into. And as a high school student and as a college student, I worked at a company called Merit Network, which was contracted. There was in Ann Arbor, Michigan, and they were contracted to do a lot of, sort of at that time, kind of NSF funded work for the internet at the time, as it was pivoting into the commercial entity that it is today. They actually provided the internet connectivity to that high school I discussed with you.
So let me get this straight. So you spent like 3 years focusing on computer science and tech, and then in 1 year you're like, you know what? I'm gonna do biology. I'm gonna do all these prereqs that I never did for 3 years, and then I'm gonna get into medical school. That's pretty phenomenal, I have to say.
Yeah, it was a bit of it. I mean, my father's a physician, and so I had some ideas to what I was getting into. He said, "You really want to do this?" And I said, "Yeah." And he's like, "You really want to do this?" So, so he was supportive, and he's a very proud father. But it definitely was a change.
I got to ask, Jim, how do you think, coming from the clinical world and then kind of bridging these two loves of yours together, how does that impact the system at scale when you're looking at technology coming from the clinical world?
Yeah, I think you have an appreciation for the different perspectives that everyone's coming to the table with. You have clinicians that are coming to the table with a very evidence-based focus, a real focus on, and also to some extent a very selfish focus, right? I mean, the demands on clinicians today are very different than they were even when I began my career, 15 years ago when I became an attending. The financial pressures are much higher, the productivity pressures are much higher, the patient care expectations are much higher. Patient experience, if you were going to ask 15 years ago about patient experience, people would be like, what's that? Not quite, but it's a much bigger thing than what we do today. And lifestyle changes have really changed with physicians as well, and what they want out of their practice and their expectations. So I think I have that appreciation. Then on the tech side, you understand the complexities of implementing tech, and the programming issues and the systems integration issues, and that, yes, system X won't talk to system Y. Yes, that's a problem, right? And we might be able to fix that internally, right? But that's a lot of development. Is that something we want to invest in, or do we want to put those resources elsewhere, and should we wait? And clinicians, I think, don't have an appreciation for the level of complexity that it takes to sometimes code these things up and develop them. Even though they use products that are produced by billion-dollar companies and with tens or hundreds of thousands of employees, there's the thought that like this team of like 4 people in the back room somewhere in their spare time can make magic happen. So I think it gives you a perspective on both sides. So yeah.
And Jim, before we get too deep onto the clinical informatics and the health tech side, I did want to circle back a bit and learn a bit more about why you ended up in anesthesiology and critical care.
Yeah, so great question. So I was a medical student in Baltimore, and at that time I was very fortunate. I was at Johns Hopkins, and we were right up the road from NIH. And so we actually had, while I was a medical student, both Francis Collins and Craig Ventnor in person for us to kind of see. And when you talk about big data in healthcare, there's nothing like genomic data, right? And you're talking terabyte per sequence, per human sequence, and so or more. And so at the time I was looking at big data and thinking about before it was called big data, right? And how do we use data from the EMR to impact medical research? And in the future, I was thinking, we'll have all this data, things that we now have. I was thinking, I think everyone saw that this was eventually going to happen. So I'm sitting there thinking, wow, genomics would be great, but it takes it's taken 10 years to sequence one person. This is, whole genome sequencing is never going to happen, right? Little did I know. So I think if I had to do it all over again, I probably would have looked into oncology or something like that. But at the time, there was a lot of data in critical care, right? You were capturing off monitors, high velocity waveform data conceivably. There was work being done with Mimic and other sources of data like that at the time. And I said, okay, this seems like an area that you can impact things. And also it was just a great high paced, field, lots of stuff going on, and very instant gratification a lot of instant gratification in caring for those patients in the OR and in the ICU. And so that's really why I focused in those areas. It seemed to bring all those things together. So.
And when you first started practicing as an attending, were you getting into the informatics and tech stuff pretty quickly, or did you actually spend some time just focused on clinical stuff before you got dragged back into the informatics world?
So through my residency, even my residency, I was very focused on a research career at the time, and focused very much on how do we use the data to help do that research. So I was involved in research very much as a resident and early in my attending career. It wasn't as much on the functional side, but I always wanted to be on that kind of clinical translational side of things, which unfortunately is a very difficult area. I think it's easier now than it was, but was a very difficult area to get funded in from the NIH or other federal agencies, because I think that a lot of things that we wanted to focus on were seen as, well, health systems should be just doing that, right? This is going to improve the care of their patients. This seems to make sense, yada, yada, blah, blah, blah. Why would you study that, right? Just do it. As opposed to, ontology development or, other things, or large data set aggregation, things like that were, I think, more well appreciated at the time. I think it's changed from where it was. But so I was very engaged in the research side of informatics. Operationally, that seemed to move more so over the past few years, my engagement. And I think really for the work that I want to do, the operation side is a great place to be, just so long as we keep the research mission in mind and we study what we do from an operational perspective.
Yeah, makes sense. So Jim, you actually mentioned already the complexities that is involved with developing a new workflow or a new technology, and maybe physicians don't always realize the extent of those complexities. I read a recent Becker's article on the impact of telehealth on rural communities. And in that article, you were sharing how your main priorities really are quite large, quite broad in scope. There's the, on one hand, the outcome of improving patient outcomes with new technologies. And then you also have to balance that with enhancing the provider workflow and their experience as well. And it's kind of like both sides of this equation. You have to balance them both. So given such a broad scope, how do you prioritize what to work on first and what has the biggest impact? How do you go about prioritizing that?
Yeah, so my focus is first and foremost on patient outcomes, right? What can we do to improve their outcomes? Healthcare, we are very fortunate to do what we do in taking care of people, right? It's a burden, and we talk about clinician burnout and all that, and I think it's real. I don't want to poo-poo it, but our first obligation is to taking great care of people. And so that is always what I'm going to look for as the first thing. How do we improve the care we deliver? No healthcare organization is perfect. How do we continue to move that needle? And so we get better outcomes. I don't think it's mutually exclusive though, right? I think if you find ways to improve provider happiness, you provide better technology for providers, frequently that can help improve the outcomes of patients. Regarding the rural aspects, I think there are some real fundamental challenges to caring for people in the rural environment. What are the resources that are available in a 25-bed critical access hospital that may be the only healthcare facility for 100 miles for somebody? How do you get them specialty care? How do you make sure that the providers that are at those locations are supported? It's one of the things I love working about the University of Iowa is we actually talk about these problems. We are focused on these problems. We see them as things that we need to do to help the providers across the state. And so I think that it's a real difficult balance to figure out where you're going to invest, where you're going to make that first step. And you need to be willing to risk things and potentially have them not pan out. but you need to, I think you need to look at this a little bit as a venture capital opportunity, except, your return on investment may not necessarily be financial. It'll be in better health for people, which ultimately pays off for us as a society and hopefully works out for the health system.
Hey, Jim, right now, like you kind of mentioned the challenge around staff burnout and the healthcare workforce is probably under more strain the last few years than we've seen maybe in decades. And there's a hospital CEO that I know who has I'll call it maybe a contrarian view where instead of putting patients always first, one of his phrases is, well, if staff satisfaction is high, that leads to higher patient satisfaction outcomes, because then if they can take care of themselves, then they can take care of patients. And as a CMIO, I'm guessing a lot of the work that you do is in improving and streamlining clinician workflow, which frees up time maybe for more patient care or less burnout. So I'm curious if you have a take on that phrase.
Yeah, I think there's truth to that, right? If people don't feel like they're taken care of, it gets very difficult for them to take care of other people. And so I like I said, I don't think these things are mutually exclusive. With that said, we are a very large academic institution, and we have very different kind of workflows and patterns to what you see at a community hospital, right? I mean, for every patient that gets seen, we have a trainee or an advanced practitioner, I think, engaged in almost every patient that's being seen at the University of Iowa. So the clinical and administrative workflow is more distributed, right? And that makes it very different from someone who is seeing patients independently in their clinic and has a panel of 20 patients in the morning and 20 patients in the afternoon that they need to see in an ambulatory clinic, as opposed to our work environments. Now we have that, right? But that's not the majority of our faculty. And so definitely looking at provider happiness is something that's important to me. We're going to start participating in the Arch Collaborative this year to assess, where are we at? We pay attention to our Epic Signal data, with a real focus on pajama time. And so we are really focusing on provider wellness, but in terms of where we're going to make, where are we going to make our biggest investments this year? It's going to be on things that are going to impact patient care, right? That's where we're going to double down, and hopefully we'll also make providers happier, and that'll impact the outcome as well.
Makes sense. And kind of, Jim, along with that thinking, you've mentioned it already, but access is one of the most crucial challenges for all health systems, and especially over in Iowa. I'm curious, knowing that access is this emerging problem. It's always been here, but it's becoming more and more evident as we scale out some of these remote technologies and things. Maybe technology isn't always the best solution to solving some of these access issues. I'm wondering, could you share like 1 or 2 learnings that you've had on this front to ensuring that access is always top of mind for the institution?
Yeah, I think particularly for us, access is something we talk about daily. I still have an appointment at the VA, and access to the VA was always talked about as well. And so this is not an uncommon discussion for me. I think that the first thing in terms of access is tech can help you with access, but the most important thing with access is triage, right? Figuring out what can wait and what can't. And there may be a tech side to facilitating workflows there and some things like that, but ultimately you need really good humans in the mix with really good workflow, really good referral ability to ingest the data that they need, and have a clinician really triage those cases. That's the first thing. And then I think having an intelligent discussion about where the human capital is going to be. It may be that you are better off not implementing a telehealth solution and packing people up and sending them someplace and having people seen in person in a remote clinic versus opening telehealth. On the flip side, there may be times where telehealth is a far more intelligent solution, right? And we're looking at doing that with our transplant program right now. When you look at getting evaluated for a kidney transplant or a liver transplant, we service the people of the state of Iowa, and conceivably someone could have a 5-hour drive to come and see us only to be told you're not a candidate, right? So we want to try to avoid that. And so our goals going forward are to be able to provide a first pass screening for folks for transplant completely virtually, including the education and everything. So this would be after, someone said, yes, this seems like a reasonable person to have a discussion with. So I think that there's balance as there's everything in life, and finding where the fulcrum needs to be is something that takes time and experience, and you need to be willing to learn from your mistakes, and that's, I think, where access really comes, how you address access problems. You can't address them overnight, unfortunately. And clearly the answer, just hire more people, is always a great answer. But so is also like, raising my salary, or, giving me gold from Fort Knox. Those are great answers too, right? So you got to work within the constraints that you have. So.
And Jim, in health systems, like I've sometimes noticed that there's misalignment between how IT and clinicians evaluate digital health solutions. So, IT often focuses on, let's compare features, and then clinicians are like, well, let's look at the clinical validation and the evidence. And not only as a CMIO, but the fact that you've come from both tech and healthcare in your training, I feel like you're in a unique position to take both into account. I saw you at the Becker's Digital Health Conference earlier this year on a panel, and you mentioned how you're pitched by digital health vendors all the time, but then you're often disappointed by the lack of evidence. And I'm curious, for clinicians who are trying to help IT and digital folks understand how to assess tech and digital health solutions through a more clinical lens, how have you helped bridge that understanding? Like, how do you advise clinicians to communicate around this with IT?
Yeah, so from a clinician perspective, I will say that I am profoundly disappointed in any evidence for practically any healthcare IT solution that comes forward. We, in the healthcare IT approach to developing evidence is, let's do a case study at some institution, and particularly from the vendor perspective, right? We do not treat these things like we treat pharmaceuticals, right? And yet many of these solutions are implemented with profound claims that it's going to improve revenue, it's going to improve outcomes, it's going to do all of this stuff, and yet there's like no evidence that it does so. So I think from a clinician perspective, it gets really hard, really hard to buy what you're being sold, and you almost need to move into the tech mindset of, okay, this seems to make sense. I believe what the vendor is selling. Let's go ahead and do that, right? On the tech side, I think we really do focus on specifications, all those types of things. And I think that we get too focused on that on the tech side of things, right? We are currently rolling out our remote patient monitoring program, and I'll be honest with you, there's there's pros and cons to all the vendors, but at the end of the day, I look at this much more as a commodity item that I just want to work, right? But whether I'm buying a Honda Accord or a Toyota Corolla or a Toyota Camry or a Chevy Silverado or an F-150, it's still going to get me to work and back. That's all I want, is something to get me to work and back. And yeah, there may be pros and cons to these types of things. And so I think on the tech side, you can get really bogged down on the nuance, when at the end of the day, it doesn't really matter, right? Just so long as it works and it does what it said it was. So choosing the best product, I think, can really lead to, and with our acquisition processes that that exist in every organization, it can really negatively impact your agility, and it negatively impacts outcomes for patients, right? When it takes you, as long as it takes to acquire products and implement them. And I think we frequently spend a lot of time looking at the bells and whistles of products, particularly on the tech side, rather than looking at things like what's the integration time, right? One of my philosophies is we should always, where possible, buy an Epic product first, right? Because the integration is easier. It's a single interface, all these things. And the time it takes to get the product stood up and implemented is going to be, half to a third what it would be to bring in a third-party vendor, right? And that's after you say what's actually acquire the product, right? It's just all the integrations, all the training, all that takes so much time. And I'm not certain that we necessarily do a great job on either clinician or on the tech side of appreciating that. I'll be honest with you. There's a lot of focus on let's buy the best product. Although I think that a lot of places are coming around to a different mindset on that.
Yeah, I think going off of a real patient-centered approach would not always be let's get the best thing, but let's get the thing that works faster and provides the better outcome. So that makes a lot of sense. I also really appreciate you've shared in the past some perspectives around predictive modeling being one of the greatest opportunities that is here today and for tomorrow. In particular, I really liked your insights on how can we leverage the technology to forecast risk and also to implement better protocols with branches that personalize medicine. I'm really curious, in an industry where lower variation of care is often the goal, how do you view the role that technology can play in actually personalizing medicine and care?
Yeah, so I think that's a really interesting discussion. So when you look at predictive modeling, I don't look at predictive modeling as personalization of care. It is population health, right? That is what you are doing with any predictive model. You are taking a population and you are applying it to that individual patient. You're seeing, where does that patient exist inside that model's output. So with that said, I think there's real opportunities to then personalize, right? After you've screened that patient, after you've applied the model, does what the model's saying make sense for that patient? And we're not to the point, I think, right now that in almost anything, particularly in the acute care environment, that you can say, okay, we're going to rely on the predictive model without having a provider engaged. And that's where the personalization comes in. It's where the provider gets engaged. I think the big problem we have right now is people don't understand these predictive models. The average provider, when you look at what they're used to ordering typically definitive tests or potentially screening tests, right? But with a screening test, then you usually say, okay, now I need to order. Very straightforward. I order the screening test, then I order the next test, which is the definitive test, right? So people aren't used to thinking about predictive models and ordering things that have positive predictive values that are, 0.2 to 0.5, knowing that half of the time that the result they get back is not going to be the right result. And oh, by the way, there's no formulaic next step what to do when that test comes back. So I think predictive modeling really involves people being educated to understand how that model has been tuned and implemented at that organization. And it's very different from traditional testing, right, in medicine. And people need to understand receiver operating curves. They need to understand how those things are generated. They need to understand precision recall, and they need to understand the choices that were made so that when they get, when that sepsis alert pops up, they know, okay, this patient is, has likely a sepsis 1 in 5 times, right? So what am I going to do to work them up at that point? it's a very difficult problem that we're facing with the integration of predictive modeling into clinical care. And I think that's why you're seeing so many bad results from studies that have implemented predictive modeling in a randomized control fashion, because you're just seeing alerts that are going off with people that don't have a good effector arm that are well educated as to what to do with those alerts. There's also an unrealistic expectation that they're going to be ultra sensitive and ultra specific. People need to understand that these are the way that these models are tuned is there's going to be a whole bunch of cases that you miss, and oh, by the way, the ones that you get alerted to, there's going to be a hit rate of 1 in whatever. And so how you educate people and how you execute on that, I don't think we figured out completely in medicine yet.
I think you bring up some really good points there, Jim. And I think one of the things that strikes me is, in medicine, I think we're often taught to ask the question, well, if I learn this insight or this piece of information, does it change my management? And if it doesn't, why am I looking into it? And I can foresee a lot of situations where if you had a lot of predictive modeling analytics in play, you can raise all these insights. But to your point, if clinicians aren't, trained or there's no expectations on acting on that insight or data, it becomes confusing as to why we're doing the first place. So for example, I'll take a anesthesiology perioperative situation. I mean, imagine if, we had some very strong predictive modeling for, postoperative complications and how we could optimize the patient. But for example, if the clinical team doesn't want to act on the information, if we, don't want to optimize these things preoperatively, then what was the point of flagging that, I guess? And so I'm curious, how do you think we can bridge that? Is it okay to say, hey, you know what, for now, we are just going to focus on the modeling, and then at some point we will figure out the path to making it actionable? Or do you feel like we have to plan around the actions first so that we can get people on board with accepting the modeling? I'm can we, what's the right path forward with?
Yeah, it's a classic chicken or egg problem. I think generating the models is a great academic exercise, right? There's all types of models that are out there floating around, in the public domain practically. And, people think they can commercialize these things. I'm not exactly sure how successful folks will be unless you're really implementing a whole bunch of other stuff associated with those models. So I think when you are looking at developing and implementing one of these models, you need to have the effector arm before you're figured out before you implement these things. We have intentionally chosen we have a bunch of models running in the background that we validated at the University of Iowa that we have not implemented because we don't have an effective effector arm. And being an intensivist and being pretty familiar with the sepsis literature, I think what you see is profound failures in a lot of these things because alerts go off, patients that the positive predictive values of these things is going to be let's just take 1 in 3 as an example. A provider is going to get that alert. If you just send it to providers in general, they're going to get that alert maybe 2 times a quarter, right? So they'll see that the 2 times they got it, the patient wasn't septic. They go and they see the patient, they look at them, they're like, this guy looks better than I do, right? So what's this sepsis alert going off for, right? Woke me up for this, right? So I think you need people to be exposed to these things. They need to see a lot of the alerts. They need to see the value of them, and you need to have them trained to figure out how to work the patient up in an intelligent format. And so I think you got to start with the effector arm, and figure out what that's going to look like, and then develop the best model you can. No model is going to be perfect. And so once you develop the performance characteristics, you can educate the provider as to what those performance characteristics are like. They can get some appreciation for it, and then they can go off and hopefully do the right thing for patients when they get that alert. But they won't walk away saying like this thing's useless, right? Because they'll understand what it's doing and how it performs. So,
and as we use more AI and machine learning to develop some of these models, we get into the situations of these black boxes where clinicians may not ever know exactly how these models are working. At some point, you are just trusting the model to be, reasonably accurate or useful. Any guidance to how we should think about how to communicate with clinicians? How do we educate around this, knowing that clinicians like knowing, right?
Yeah.
It feels good to control over that.
I think explainable AI is overblown, would be my comment, right? I think that folks want to understand this, and nobody's saying, tell me how the facial recognition on my phone works, right? Like people just trust it, right? I think what it comes down to is being explainable AI. I'm less concerned about than people having the performance characteristics and understanding what the model is going to generate. I think is important, right? People like to know, beta coefficients and those types of things. That's why logistic regression is such a sought after commodity, I think, in a lot of things. Or people try to apply similar things like shapely curves or that type of thing to other modeling techniques to try to come up with explainable AI. I think that is not entirely helpful. I think really my opinion is that we need to be educating providers on understanding the performance characteristics of the models and how to interpret the results, much more so than telling them why the model is firing, right? I think that is a long-term a losing argument, right? Because the best models likely in many situations are not going to be fully explainable, particularly as we start to implement deep learning and those types of things. Unless you want to go back and teach people linear algebra and all, and under that and understand all that stuff. And I jokingly used to say, like, I don't think anyone that doesn't know what an eigenvector is should be I don't believe that any longer, right? I think that there's enough black boxes out there and people don't necessarily need to understand the complex math to be able to make use of this technology. Even as people that are developing models, they probably need assistance with someone in doing this, with someone that does understand that stuff, to make sure they aren't doing something stupid. But I think that AI for the masses is here, and by letting people experiment with this to some extent and develop models using these technologies, and understanding that maybe they don't understand entirely what it's doing, they'll develop better appreciation. But as long as they understand how the model's going to perform, I think that's the important thing.
So to interpret the performance of the model, and I'm curious, what year in the future do you think education on these topics seeps into that medical school curriculum? Like, how far away do you think we are from that?
Well, I think we're getting closer, right? I mean, I think, so I recently had to give a talk on this, and you look at the literature and you start to see in cardiology journals, even as far as 10 years ago, people were explaining receiver operating curves and precision recall and that type of stuff. And so I think the issue is people don't necessarily get exposed to this stuff on a routine basis. And when you look at biostatistics, right, it's 3% of the USMLE. Most people memorize a bunch of stuff and then it disappears because they're busy, trying to pass their boards and that type of thing. But like anything, as we start to use these technologies and people come up with education curriculums, this will become part of the vernacular, that we, and we'll have intelligent conversations. I think that'll happen in the next 10 years. But I think we need to make a conscious decision when we implement these things to start doing this. And I'm not sure we do that, right? But if I think we're going to be forced to. Yeah.
Are you, I'm just curious, like at Iowa, is there a clinical informatics fellowship? I'm seeing those pop up more and more in different schools, but.
So we are in the process. We've approved funding to start one. We are in the process of submitting our application to the ACGME at this point. In fact, it's going over to our GME office today. So we're hoping, if anyone's listening to this and interested, send me an email. We'll be hopefully taking applications sometime starting in January or so, if assuming we get approved. Yeah. So
very neat.
That's awesome. Jim, I had one last question for you. You brought up earlier in the conversation your interests in the omics, like genomics and proteomics and all that. As advancements in those fields start driving, again, more personalized, better care, there's already this huge body of literature that no one person can actually consume and digest and understand and filter. I think you've hinted in the past, we need to undergo kind of like a fundamental change in workflow and human interfaces or computer interfaces with humans, as well as data processing to really take full advantage of all the patient's data. How do you envision the future where this sort of level of data acuity and processing is possible?
Yeah, we're, I think, just starting to get to the point where we can routinely start to take advantage of genomic information, right? We now have genomic packages from the major vendors. No longer is the PDF going to be the primary mode of exchanging genomic data. As we begin to understand omics, and we do metabolic profiling that is at a level that is very different from what, when we talk about metabolic profiling right now, we're going to need expansions of the EMRs to metabolize that data and provide the data structures for us to operationalize that. And I think genetic data, we're starting to do that without becoming a CDS nightmare, clinical decision support nightmare, which I think you could very rapidly do. I think we need to be thinking very intelligently about what does this look like, right? Where are we going to intervene in the clinician workflow? Where are we going to potentially turn this stuff over to population health to manage and identify, okay, this patient has a genetic propensity for colon cancer. So we're going to be ultra aggressive in getting them in for their screening from a population perspective. Is that going to rest with their primary care doc? Are we going to somehow in our population health push that information to the provider in some other mechanism or directly to the patient? Who's going to do the education, right? It's going to be complex, is the answer. What the answer is not just firing off, 15,000 BPAs every time a patient's in somebody's clinic, right? And so how do we intelligently integrate this data into the clinical decision support in a seamless, or I won't say seamless, but in a relatively low friction pathway for providers so that they aren't just, dealing with stuff when it pops up on their screen. And that's going to be really important. And I don't think we figured that out I don't think we figured that out yet as a healthcare system, right? When you look at a lot of solutions that are out there right now, it's, oh, gee, we can provide you access and we've got this really great intelligent genomic database and we'll link it into Epic and we'll fire a bunch of BPAs at your providers. That is probably not the right answer. In certain cases it is, like pharmacogenomics. I'm about to write a drug and I'm going to really overdose somebody based on what we know about some specific allele they have. That's probably appropriate, but it's probably not appropriate for closing their after visit summary saying, oh, by the way, did you remember this patient needs a colonoscopy, right? That's probably the wrong time to bring that up. So
it almost seems like it involves a personalization of the workflow as well, based on what the information is saying.
Yeah,
that's very tricky.
It's going to be very tricky. And I think the big problem right now is every institution is faced with, you should develop this on your own.
Yeah.
And think about how your how the workflow is at your institution. And I think that these are very complex problems that we would be better off if we had some sort of national collaboration surrounding.
Yeah, I could totally see that. All right, Jim, just being mindful of your time, let's flip over to what we call the Fast 5 lightning round. 5 questions to get to know you better for our audience.
Okay.
First question we have, what is your favorite book or book you've gifted the most?
Oh, that is so fiction or nonfiction?
We could do one of each if you prefer, or I mean, we've had fiction, we've had nonfiction, we've had it all.
Okay. I would tell you that probably my favorite, uh, uh, well, of late, probably the most recent thing I read was Leon Panetta's kind of memoir, and that was really interesting. So that was a great kind of a really interesting book about his time in the Clinton White House, which is
Wow.
very, very interesting.
Mhm.
So I would list that as kind of my favorite book right now. In terms of fiction, I really enjoyed Tom Clancy's kind of early
Mm,
stuff. It was
nice.
fun. It was fun to read, right?
Oh,
It's
totally.
not great literature, but it's fun.
Yeah,
So
exactly.
yeah.
Oh, I love that. Question 2, who's a person either dead or alive you'd love to meet?
I would say Winston Churchill.
Oh, nice.
I
Yeah.
think some to lead a nation through that level of adversity, just in being such in speaking so forcefully and elegantly in those times would just be really interesting to meet the person and get to know what he was really like, right?
Yeah,
Yeah.
that's awesome.
Yeah.
Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Read people's minds.
Nice.
Without a doubt.
Now we do have a follow-up for that one. What if you couldn't turn that power off?
Well, I should ask my wife. She reads my mind. So she doesn't seem to be able to turn it off. So we can see what it's like. Yeah. Quite
So,
true.
but at least now you'll be equivalent in the relationship, right?
Yeah.
Yeah. Yes. There we go.
Exactly.
Yes.
Although you'll be reading her mind, which will just be reading your mind, and then you'll just be lost in your own thought.
You just won't be talking.
Yeah.
Yes. Yes. Exactly.
That's good.
So. Yeah.
Question 4, Jim. What is something in healthcare you believe that others might find insane?
Oh, in the U.S. healthcare system, the entire economic process of healthcare. I mean, I don't know if anyone that's actually in it understands it. But how we got here, I mean, this is crazy, right? How we pay for healthcare is just beyond nuts.
Mhm.
It's rule upon rule that has been built to keep the system. It really feels like a house of cards.
Yeah.
So,
We were talking to a CMIO yesterday who says, when her patients ask her, how much will this cost? And she's like, I have no idea.
Yeah,
Mhm.
right. I had no idea how much this costs. And then when you start to ask inside the organization, how much does this actually cost us? People have no idea, right? I mean, what business outside of healthcare says we have no idea how much it costs to produce the product that we're selling,
Mhm.
right? I mean, it's just absolutely bonkers, right? And how much are we going to get paid for the product? We don't know, right? Like, who else would operate like this, right?
So true.
Yeah.
Very complex.
Yeah.
Last question that we have, this is a pandemic lockdown related question. What is one hobby or activity you've gotten into since the beginning of the pandemic?
So when just as the pandemic was getting rolling, I was actually starting flight lessons.
Oh, nice.
So I'm now heavily, and this was actually related. I was doing some work at Oak Ridge National Labs, and I was driving back and forth. It was about 4 hours each way. This was with the VA, and so I almost got killed. And one of my colleagues, who was a pilot, said, it's only a 45-minute flight, to Knoxville from Atlanta. I was in Atlanta at the time at Emory University in the Atlanta VA, and so I was like, well, he's on to something, right? I could I was leaving at 4 a.m, getting there at 8,
Jeez.
meetings from 8:30 to 4 and driving home starting at
God.
4:30. And I was like, wow, I could get up at a reasonable hour, fly up there, be home for dinner. So that's where it started. And now that I'm in the Midwest here in the upper Midwest, it's a great skill to have to get around and, get to meetings, that type of thing.
That's so cool. So you got your license?
Have my license, have my instrument writing. I'm in the process of getting my commercial rating.
Wow.
So Yeah. So
That's awesome.
yeah, and
Very
there's
cool.
a lot of great parallels to medicine, right? Lessons that we could learn from aviation
You
to
mean like
apply to
checklists
medicine.
or? I was-
Well, above and beyond checklists, right? I mean, the focus on safety, right?
Mhm.
I mean, checklists are just a part of being safe,
Mhm.
right? And the focus on safety and the focus on safety, and we talked about provider well-being, right? So one of the things before you get in an airplane as a pilot is, you've got this thing. Are you, literally it's the I'm safe kind of, it's an acronym. But are you safe to be doing what you're to be flying that plane today? When's the last time you heard a surgeon, right, or an anesthesiologist get asked, are you safe
Mhm.
to be doing what you're doing today, right? And we talk about provider well-being and all that, emotional burnout, but just how about, did that person get a good night's sleep?
Mhm.
And if they didn't get a good night's sleep, you shouldn't get behind or if you're fatigued, there would be the comment, you shouldn't get in the cockpit, right? When's the last time you heard a surgeon say, something, I'm fatigued, I'm going to cancel my case today?
It's funny because like pilots are forced to clock out after a number of hours. That doesn't happen in medicine.
Well, you're only forced to clock out after a number of hours if you're flying under certain parts of what's called the FAR. So, if you're a private pilot, you can go ahead and fly as much as you want. There's no regulations. So, and depending, on what part of the FAR you're operating underneath. So, yeah, I mean, I think that but you shouldn't be thinking about that. It shouldn't be what the regulations are. It should be, are you feeling like you are well equipped to do the case? And I've never had a surgeon, except for someone that was up literally all night operating, say, I'm tired. I've been in the operating room. I've had cases scheduled where I, didn't sleep well the night before. I was feeling maybe a little under the weather. Was I bringing my true A game to the table that day? No, I was not. Right. And a culture of saying you really should be only doing things if you're well equipped. But then the question comes up is, where's the redundancy in the system, right? In airlines, right, they've got pilots literally sitting around waiting because someone says, I can't fly today, right? No health system has that. Why? Because we can't afford it, right? You have surgeons sitting around, anesthesiologists sitting around doing nothing if someone's going to be sick. And so I think there's a lot of lessons from aviation that go well beyond the checklist, that if you were going to re-engineer the healthcare system, you could learn a lot from.
Wow. Yeah, that's really cool. I love that. Well, awesome. Being mindful of your time, Jim, let's wrap it there. But thanks so much for coming on the show. It's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at SeamlessMD. If you like the podcast and you want to learn more, visit www.seamless.md. Jim, again, thanks so much for coming on and sharing your time with us today.
Thanks so much. Have a great day, everybody.